Welcome back to Heal the Burn. I'm your host, Dr. Steven Sears. Today we're shifting our attention to the front end of the pipeline, to the students and trainees who are just entering medicine, and to the people who are shaping them. My guest today is Dr. Bud Isaacson. He is the former executive dean of the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University, a general internist, an educator, and someone who spent a lot of time thinking about how to train providers who can do this work for the long haul without losing themselves. If you listened to my last episode, you know that Bud turned the tables and interviewed me about my own journey with burnout. Today, I get my microphone back. Bud, thank you for coming back on Heal the Burn.
Oh, my pleasure. Looking forward to it, Steve.
So, what did the beginning of your journey to becoming a doctor look like?
Yeah, I actually came from a family that had a number of physicians. My father was a physician. I had two grandparents who were physicians, including a grandmother, which was pretty unique.
It is.
My grandparents were psychiatrists, my father an ophthalmologist. And I went to school, high school and undergrad with a really close group of friends, and many of them wanted to go into medicine. And I think I
Mm.
sort of rebelled against that initially. That I do not want to follow this path. So I sort of intentionally tried not to go into medicine at the beginning, just saying I'm going to look for other things. And I was actually an economics major at University of Michigan. And then I started to explore what my career interests would be, and I think drifted back towards the types of things you could do in medicine.
Mm-hmm.
Which at the time, my father had always told me you had a lot of independence, which you
Mm-hmm.
certainly don't have now. But at the time, you had medicine as a career. Really, you could go out and be independent. Really, the idea of higher calling of being with people and helping people. I saw a little bit of that role model from my father, and I drifted back. So I started taking pre-med courses when I was a junior, and it was interesting being the older person in the class with all the freshmen. And lo and behold, I decided late by senior year I wanted to apply to medical school, and I applied, and it really was the right decision for me. So it took me a while to get there, but I feel good because I explored other options first, and it still was the right decision for me.
Do you remember when you started to have a desire to move from practice to a more senior leadership role?
No, I never really envisioned that. I would consider myself an educator in addition to a physician. I think my primary identity is still as a primary care doc. I ended up in a primary care residency program and in University of Vermont, a
Mm-hmm.
small place. And a pivotal moment for me was I was interested in becoming a chief resident, and chief resident in a career in internal medicine, sort of like a junior staff position. So you're able to sort of be that in between the residents, first, second, and third year residents. You're sort of overseeing them and their schedules and an intermediary between them and the attending physicians. So you're sort of a junior attending physician. And I really enjoyed that role, really an education role. You know, you were in charge of a lot of the education conferences for the residents and trying to help them have a reasonable schedule and solve problems with them. And so when I finished my training, it wasn't really leadership. I said, I want to be involved in something that I can still do education. So I looked at private practices
Mm-hmm.
briefly, but I decided I wanted to be into some sort of situation that would allow me to be around trainees and teach. So I started out at the Detroit Medical Center for my first role because I was from Michigan and that was going back near family. And then I got even more exposed to educational opportunities at the Detroit Medical Center. Just by chance, I lucked into getting involved with a faculty development grant where they were training junior faculty to help become knowledgeable about alcohol problems and substance use problems. but it exposed me to adult learning theory. I had a chance to get involved doing some hands-on teaching, building on what I'd done as a chief resident. So I really enjoyed that.
Yeah.
And then I got recruited to Cleveland Clinic by one of my former mentors in Vermont, my residency. And so when he asked me to look at a position here, I said I want to do something that involves education. And so I got involved, practice and education right from the start.
How long did you practice before you became executive dean?
Let's see, I came here in '93, probably involved with residency education for the first 10 years of my career. I helped
Mm-hmm.
run the primary care track and all of the outpatient practice for internal medicine residents. We started planning for Cleveland Clinic Lerner College of Medicine in 2002 and opened the doors in 2004. So I was involved in the planning for that. That was fascinating, really trying to build a program with others ground up and looking again at some new principles of how you want to educate future physicians. And our principles, I think, are probably relevant to this discussion because it was much more based on collaboration
Mm-hmm.
and teamwork and small group learning with students having an active role in their education as opposed to getting a lot of lectures. We don't have tests, we don't have grades. So I had a role at the beginning as the assistant dean for clinical education for several years, which I enjoyed very much. And that was really thinking about any part of our curriculum where students were involved with patients. And we started that year one and continue till this day. So I was in that role from about 2004, and then 2018 is when I was asked to become interim executive dean when the current one got promoted, and I ended up staying on and just recently stepped down from that role at the end of 2025.
It's been a long journey, an amazing time. You've seen so many people from start to finish. I think that's a really unique place to get to be and look at all of this from that perspective. Do you remember what convinced you that you wanted to be that the being the executive dean would be a good fit?
Well, interestingly enough, it's not something that I really aspired to. I was very much engaged in enjoying the role as a clinical dean,
Mm-hmm.
and when approached, I think I felt a bit of the imposter phenomenon that is very common for us in many of our roles. That certainly applied to me then. Sort of, who me are you looking at for this role? I never
Mm-hmm.
would envision myself with that title associated. And I think if you ask some of my friends from high school, undergrad, med school, they would sort of laugh if you told them that was going to happen at some point.
We won't pull on that thread.
I viewed it as a team effort more than an individual thing. And I viewed it as being asked to step into a role to help the team. The team needed someone in that position. And it became a great growth opportunity for me to try to continue the success of our school and see what I could do to continue that success, build on that success.
Mm-hmm.
So it's been a fun journey, but one that I never anticipated.
So, from where you stand now, what are you seeing that's different, say, when you first started with the school, about the learners, about the students who are applying?
Well, I think the landscape of medicine has changed so much, and any med school has to be aware of that and responsive to it. So many things have changed. Our school's been is a young school. We've been open now. We're for 21 years, getting into our 22nd year, and that's a pretty recent history compared to most traditional schools that have been open. This case has for something like 175 years. Um, and I think what we're seeing now is a very high pressure environment for students. Artificial intelligence is certainly the big disruptor that we're seeing since ChatGPT came out in 2020. two, I guess it was, or three. It's relatively such a short time, and many pressures on students. And I think that the environment in which they're going to have to be prepared for and leave med school is one that is rapidly changing. Having said that, I mentioned our sort of the guiding principles that we use to help us make decisions about how to develop our school. Many of them still have held true, really, despite the changing landscape of medicine. This idea of trying to work collaboratively, I think, was a little bit foreign 20 years ago. Now it's
Mm.
very relevant. I mean, I think we
Hmm.
all know that medicine is a team sport. The adjustment that our students have to make, they did back in 2004, still have to make, is one of coming from a highly competitive environment. Our school is very difficult to get into, and I joke, but it's actually true. I could not get into our medical school if I was trying. Would not be, wouldn't have even gotten an interview probably. So you've got this super competitive environment that students have to achieve and score well on their MCATs and demonstrate a whole range of skills and interests in order to be competitive to get into any medical school. And then, wow, they come into our school and we ask them day one, hey, no grades. You're not going to be competing for class rank against your peers. You're going to be working together with your peers and you're going to be learning in small groups and you're going to teach each other and your ability to be present and to show up and contribute is critical for the success of our school. So that's a fundamental shift that all our students have had to face. Um, it's tough. It's a tough one for them, and they make that adjustment at variable rates. And some it's easier, and some it's difficult. And what we found is we have to provide the students a lot of support along the way, and not let them just sort of flounder on their own. That's certainly something I think is far different, probably I would imagine for you as well, from the type of environment I was in medical school, which was very much one of sort of being on your own. Just, good luck. It's a tough
Yeah.
curriculum, and you're out there with peer support, but not much formal support from a school. You're sort of it's like you throw you in the water and you sink or swim. See how you do.
So, especially during and after pandemic, did you notice any themes in the things that were distressing the students in the program?
I'm glad you brought that up. The pandemic was a huge disruptor, and I think that was a huge challenge for all of us at the school, the students, the faculty, the administrative team. And I think what we learned, how much stress that put on our systems in so many ways, and how much stress it put on individuals. And one of the major disruptors, as we know, of the COVID pandemic was decreasing the amount of time that we're together making meaningful connections with our peers, with our faculty. And we had a class that started in the summer of 2020 with the pandemic hitting in March. We had to roll along, and we had a class that literally worked together in teams, but virtually. We were in virtual Zoom rooms, and it was an incredible effort on their behalf. I have so much admiration for them and the team we assembled to try to keep some identity and cohesion together over that year. But it produced a lot of stress and strain on everyone. It brought the team together in many ways. But we've seen, I think, that COVID exposed this. But I think the pressure that students are under now, we see a lot of them, have struggles with the stress, and it can manifest itself in behavioral disorders and depression and anxiety and all sorts of things that now we try to acknowledge and help students through and create safe pathways for them to be supported so they don't have to sort of hide these types of things. I think that's another big change I've seen in the generation. I'm sure a lot of that was going on when I was in school, and maybe
Hmm.
for you as well. I don't think there were the types of support systems in place to try to, focus on student wellness and provide
Agreed.
pathways. Yeah.
What are things right now about the students that make you feel like saying, okay, the future might actually be better than the past?
Oh, that's a great question. I am so optimistic about the future, and I think I can tell you some of the things that have been very important for us, and I think and many other schools. We have a big focus on reflection and reflective practice. That's actually one of our core competencies. So our students have 9 competencies, and many of them are traditional things like clinical skills and communication skills and professionalism. But we have an entire competency on reflective practice. And that competency is something that the students must reflect on, but students compile portfolios, which are essentially reflections on how they are performing relative to the competencies and educational program objectives or milestones that we've set out for them. And so they have a lot of guidance along the way from trained faculty who serve as physician advisors, but they are asked to reflect on their journey. This reflective practice component asks them to look at how they're developing personally, professionally, where are they having the most success, where they have opportunities to grow. So it's a system that tries to encourage reflection to get better and accountability with a lot of support. And what we see, I think we're very optimistic because that is a type of a sort of skill set, if you can develop one of reflection and desire to grow and improve, that serves physicians very well when they get done with training. And it's something that was not part of my training. I think we're recognizing now how important it is for you to have space to reflect. And we have tried to build in not only in their portfolio, but other parts of their curriculum where they have safe space to reflect with faculty who've been skilled and trained and interested in these roles to help mentor and guide and help the students process their experiences.
That's great. And I love how that circles back kind of to the topic of the conversation. You'll run into people who say, well, reflective practice is great if you have the time. We're worried about board scores, we're worried about productivity, we're worried about paying off student loans and stuff. I mean, how do you talk about these things and their role in medical education? How can we make these reflection paths more important?
Right. Again, a great question. I think we're very fortunate, when someone's in school, some of these demands that occur when they're done with training, like productivity and the demands of practice, we don't have to worry as much about that. We really do have control over their curricular time and schedules. And so I think what's important is we just don't talk about it. We immerse our students in these experiences. I'll give you one example. A course that I was involved developing early on that has evolved and is continued to grow and I think become very meaningful for our students. We have a course, many schools have something similar called the Art and Practice of Medicine, where typically in the first few years they're learning about physicians' role in society and their own responsibilities to themselves, to their peers, to society at large. The part that I think is especially meaningful, again, many schools have variations of this. We have a component of art and practice medicine in the third year, where every month the students come back to our campus from whatever clinical rotations they're on. The third year, as most people know, is when students are rotating in the clinics and the hospitals. Very stressful. They're seeing a lot of things for the first time. Their workload is very intense, and They may be seeing things that excite them. They may be seeing things that confuse them. They may see role modeling from physicians that is great. They may see role modeling that's not so great, and they may see disruptive behavior, etc. What we do is we allow our students to come back once a month, and there's usually a topic around professionalism that we discuss. But then what really is meaningful for our students is we have them in small groups, a cohort of 8 students with a couple faculty, and that group gets together usually for an hour and a half on a Friday afternoon once a month for the year. And it's a group that confidentiality is stressed, the safety of the group, what's discussed in that group stays in the group.
Mm-hmm.
Again, there's no grading or evaluation of that other than we expect our students to attend. Uh, we ask them to reflect on their experiences. We have some reflective writing as part of that course where they're asked to reflect on any number of topics, but things that have excited them or troubled them. But they also get to talk as a group, and for that hour and a half, really open forum on what is on their mind. And that ability to process your experiences in medicine is something that's so important. To hear that something that you felt is felt by your peers and to feel validated and to understand that you're not alone in your clinical experiences, because many students will feel alone on different rotations. So I think our students really enjoy that. When I've been involved teaching in that class in the past as a facilitator, and it's such a rich experience to hear the students' stories, to let them process that, and they learn so much from their peers, and that space really allows them to continue to develop their professional identity. That's something that's really important, is that sense of who they want to be as a physician, which is unique for
Mm-hmm.
each individual student. But giving them the space to process these experiences. This is a long-winded answer, but I think if we can have our students experience that reflection and see the value of it, we hope that they will move on after they're done with us into residencies that have some of that space. And then I think look for that type of space in their practice, which admittedly will be more difficult and they will have to be more creative. But I certainly feel like being exposed to that has opened my eyes and made me appreciate the chances in my own professional career to be in groups where you can reflect. Things like the coaching programs where you can stop and reflect, you know, groups that you have among professionals who get together and are able to share their experiences are so valuable.
Actually, I wanted to dig into that just for a second. If you're somebody who didn't go to a place like Lerner, and maybe you're in a busy practice now, or you're feeling stretched, is there a small reflective practice tool that you could share that people could realistically try without making it feel like homework, but it might be helpful?
Yeah, I think, reflection can come in various doses and forms. And in its simplest form, I think it can be solitary and it can be trying to create space for yourself to reflect on what you've experienced through the day. And there's no right answer for everyone. They've got to find their own. For many people, it can be getting out away from their professional environment. It can be
Mm-hmm.
taking a walk, going out, enjoying nature. For other people, it may be doing some mindfulness, a brief exercise, even for 5 minutes with some deep breathing and just closing their eyes at the end of the day. And people have to find their own individual uh, rituals that work for them. That says, at an individual level, I think there's so much value of connecting with other people, though, and finding space to do that. I know I get enormous benefit from having informal, unplanned, unscripted discussions with trusted colleagues. And so I would encourage people to look for opportunities in their professional roles where they're able to be with other colleagues and take advantage of those opportunities when they exist within your clinical practice. If they don't exist, then think about ways you can create that. And I've seen many examples. Again, no one solution for everyone, but I've seen examples at the Cleveland Clinic where I work. People having book clubs over lunch once a month. People just getting together for coffee, having some time outside the walls of the clinic where someone meets, even for for a happy hour after work. Just finding ways to make a human connection and to share things. You can feel so much better after a tough day after you've made
Mhm.
that meaningful connection with someone.
That really resonates with me. I think even doing this podcast, I realize has become reflective practice for me. I get to sit with these stories and make sense of what we're all seeing in medicine. It doesn't fix the inbox, but it kind of changes how I hold the inbox. So thanks for that. If we're serious about reducing burnout for the next generation, what needs to change in how we train and support our learners?
Yeah, great question. I do think it's the experiential that matters. So I think from a curricular standpoint, as I mentioned, creating experiences that give students permission and encourage them to share, be vulnerable in a safe space and be supported. I think there's a great opportunity to role model. I know really enjoy teaching, and you have a tremendous opportunity when we're with students or residents in the context of patient care to share the joy
Hmm.
of patient care, to
Hmm.
make those experiences meaningful for our students. And it involves some pretty simple things. So I like to say, treat the students as you want them to treat your patients. So that means simple things like getting to know your trainee, getting to know their names, getting to know a bit about them, whatever they want to share, just like we will with patients. Trying to find out what their unique interests are, what they want out of medicine, trying to encourage them, trying to help them grow in their experiences in a supported way. Little things matter. I remember when I visited your office, I was so impressed. The fact you set aside some workspace for trainees. It sounds like a really little thing, but the message to a trainee is I respect you as a colleague and I care about you and I want you to be comfortable in the space. And that goes a long way. So I think the learning environment that we provide is so important.
Hmm.
Our students can enter an environment, and if ideally they feel welcome, they feel tended to, they feel like someone is interested in their growth and learning, it can be a really positive experience for them and a super positive experience for the person training them. I find it one of the most uh, invigorating things is to have sessions with students and debrief with them. It's that one-on-one connection.
Hmm.
I was in clinic this morning, had a student, and we were focusing on a very little task of how do you engage some of our patients in their own plans. And we talked about how you can ask patients at the end of the visit, what are they taking away from the visit, and learn so much. And we had a great dialogue about that. So when you have that dynamic of you working with the student and sharing insights and supporting them, it's great for both of you. And I think that modeling goes a long way. And what we're trying to really push back against is when the learning environment is not supportive, when a student or a resident is there and they don't know what their role is and they feel like they're not fitting in, and
Hmm.
self-doubt can come in and they don't feel supported or like they have any meaningful role. That can make them feel isolated and lonely and set them on a path that is unhealthy. So I think we have a huge opportunity as physicians who train the next generation to try to model the environment that we want for ourselves, for our patients, for them, to allow them to feel supported and grow. So my hope is that when they see that and it works for them, that they'll bring that with them when they leave wherever they go and recognize that importance and pay it forward. And I've seen students from our medical school who've stayed on here for residency, and now we have 30 of our students who are on staff.
Wow.
It is so gratifying, I tell you, to interact with them now as they are staff. For me to send a patient to someone that I worked with in clinic many years ago, and knowing how they're going to care for patients, it's the full circle, and it's incredibly gratifying, and that's really makes me optimistic about the future.
That's that's great. I'm thrilled to hear that. I want to bring it back to someone who might be listening to the podcast who's like mid-career, maybe feeling worn down, but is really deeply concerned and cares about the next generation. What is your what is your message to that person?
Uh, my message is they have an incredible amount to offer, and they may not realize it. And so, if they're interested at all in being involved with the next generation of physicians, get involved. Invite someone to work with you in your clinic, in the OR, wherever you practice. And I think you'll find it to be a very rewarding experience to see people who are new in their career, who are excited, and to feel that excitement and share the wisdom that you have. And it really, again, it's a two-way street. They get a lot out of it, the trainee, but you will get a lot out of that, I think, as a practitioner. And really, I think have some gratitude for yourself and recognize how much you have grown and how much you have to offer trainees at your level. It's really not about medical knowledge at this point. Most of the students are much smarter than me. That's not the issue. The issue is you have wisdom, you have experience, and you can share that with them and help them grow. And it's really I find it very exciting. And I think for those who are feeling like, how can I make an impact? It's really a rewarding way to do that.
Listen, before we wrap up, I wanted to go back to something you had said that I hadn't thought of, and that is, do you have a sense of how AI is going to change what kind of doctors we make from schools? You know, even if it's a limited program like Open Evidence that, just uses current medical knowledge, but the fact that kind of anyone can look anything up in a such a new and powerful way.
Yes, very good question, complex question. There's not a simple answer. I think we're at the forefront of this. We're spending a lot of time at our school, and luckily we have some very thoughtful people trying to examine this. So, number one is we need to embrace AI and not try to run away from it. And so that's fundamentally one thing we have accepted is you cannot just say don't use AI. That's not a realistic expectation. So the real challenge is how to thread the needle to allow students to take advantage of this while still developing critical thinking skills. And there are some studies now showing that they're talking about de-skilling. So someone who becomes overly reliant on artificial intelligence may some of the skills that they used in the past may atrophy. So we have to be very concerned about that, especially with novice learners, early learners who may not have developed the skill set around clinical reasoning, for example, to the extent that we want them to. We have to combine using resources efficiently while also stopping and critically assessing the information they get, saying, does this make sense? Because we know there are gaps in that. So there are many different exciting opportunities. I'll just mention a couple. I think the idea of using an AI as a tutor to allow students to have individualized learning plans and have the AI expert to help them guide some of their learning around content is very exciting, and we're looking at that. We've done some
Mm-hmm.
pilot work in some of our basic science courses. And the caveat there is that we're not letting them search the World Wide Web. We're giving them the AI universe for that is the course content developed by experts. So it's a sort of a closed system.
Mm-hmm.
And that but the student can, in a safe manner, identify areas that they want to learn, and if with this type of system, sort of self-tests, self-study guides can be created very quickly and individualized. So that's exciting. The idea of how do we have tutors fit in. The other thing we've talked about, some of my colleagues who are more expert on this, is having some times where you don't depend on AI for all your activities. So maybe taking a break. So maybe you use it for some of your assignments. You allow students to use it and critique the answers you're getting. But other times you say, you know what, for this case, you're not going to be able to use any of the online resources, open evidence, or anything. I want you to think with me about this patient, and you can't look anything up. Okay, if we can create a safe environment and let people sort of continue to use the muscles involved with clinical reasoning without reliance on an external source. So I think there's a lot of potential. I think we will continue to evolve, and it will be part of our medical landscape. And excited about the opportunities for it. I think we'll be hopefully generating some meaningful information out of our school, studying how to do this effectively.
I'm excited to see that kind of research for sure. I enjoy when I am mentoring students and residents to just do a analog differential diagnosis on the whiteboard and dig and dig and dig and dig until we can't come up with anything anymore. And I think that really is a different experience than just how you can look stuff up.
The other thing I would say is, as you and I know, being primary care docs, AI cannot substitute for the meaningful doctor-patient relationship, and being
No.
there and seeing what's going on with your patient in real time with a visit and responding appropriately and trying to help them navigate complex situations. It's not just about medical knowledge and answers. There's so much about the humanity of medicine that we have to bring to the encounters that AI will never replace.
But thank you for the work that you do. Thank you for taking the time today to share your perspectives. I really do. I honestly have faith in the future because of leaders like you.
Oh, I really appreciate the time, Steve. Thanks for your kind words. It's been a pleasure.
I want to come back to something Bud said near the end of our conversation about how much mid-career physicians often underestimate what they have to offer. I get that is a story a lot of us tell ourselves. And what really struck me is that teaching isn't about having something extra to give, it's about letting someone stand next to you while you do the work that you already know how to do. You're narrating your thinking, you're showing how you talk to a patient when the answer isn't clear. Modeling what that looks like to care, even when the system makes it hard. And the unexpected part is this. When you create those experiences for learners, it doesn't just help them, it gives you something back too. It reminds you why the work mattered in the first place. It turns an ordinary day into something shared, something lighter. I'm also excited to hear about how medical education can change to build resilience. Maybe not burnout proof, but certainly adding layers to our future colleagues to help keep them lit. Please share this episode with someone who may be struggling if you think it could help. This is Dr. Steven Sears. Thank you for listening to another episode of Heal the Burn.